Hello and welcome. We're thrilled to see so many of you join us here today for the live webinar, Visualize Your Needle, Ultrasound for Painless and Accurate MSK Injections. With over 2,900 registrants for today's webinar, ultrasound for guided injections is certainly a hot topic. I'd like to thank our friends at AAOS, ACSM, and the CPA for inviting many of you to join us today. Thank you so much for joining us. You're in for a dynamic and highly informative event with guest expert Dr. Alan Hirahara, who is board certified in both orthopedic surgery and orthopedic sports medicine. Dr. Hirahara will share his master tips for visualizing your needle and targeting anatomy using high-definition ultrasound for highly precise injections to treat pain effectively every time. We're excited to introduce you to Dr. Hirahara in a moment, but first let me introduce your host. Dr. Oran Frankel is trained in emergency medicine in California, has been using point-of-care ultrasound his entire career, and is a passionate POCUS educator. He now practices in a busy academic teaching hospital in Vancouver as an emergency physician. When he's not saving lives, Dr. Frankel also serves as chairman of our Clarisus Medical Advisory Board, bringing you educational content like today's event. Welcome back, Dr. Frankel.
Thanks, Janelle. It's good to be here with a topic that is near and dear to my heart and something that is almost present in my daily practice, which is ultrasound for musculoskeletal injections. To set the stage for our discussion, we did a literature review, which is pretty overwhelming at this point, with about 10 years at least of research that really overwhelmingly supports the use of ultrasound in MSK injections. And to just give a sense of what the landscape looks like, we wanted to kind of go in with what the kind of bread and butter presentations are and bread and butter uses for MSK ultrasound. So starting kind of with knee ultrasound, and particularly with intra-articular and peri-articular joint injections, ultrasound has shown multiple advantages over traditional radiologic imaging modalities when it's been used for interventional procedures, because it allows visualization of the anatomy while you avoid radiation and the risks associated with contrast use. And so ultrasound can really enable us to see soft tissues, vascular structures, and also neuraxial, periaxial, nerve, and even joint-related structures. And to give some examples of where specifically MSK injections can be useful, we think of the knee as bread and butter as our joint. And in this example, which was randomized to a contrast dye gold standard, so when they did injections, they could see exactly where do the injections go. And using ultrasound guidance compared to the blind injection, which we use with just anatomic landmarks, they found that the radiographic image that was obtained with the contrast showed that the ultrasound really helped nail it right into the joint almost 100% of the time compared to blind injections. And as we move into additional applications, we can look at, there's so much literature we couldn't really represent or review all the papers, so we had to kind of stick to some of the systematic reviews. And in this systematic review that we can take to as a summary of the state of the literature, really blind injections over and over again end up resulting in inaccurate, imprecise injection patterns, which is not surprising with the anatomic variation we see in our patients and the different puzzles and tricks that they present to be able to get it into the joint space. As one last example I wanted to bring to, which is a little bit more of an advanced injection, but still one that we do really commonly, which is a subacromial bursa injection. And we'll see later that in this systematic review and meta-analysis, ultimately, we're mostly interested in clinical outcomes, which is always the question that comes up. And we find that ultrasound-guided subacromial injection really offers greater clinical improvement in the long term. And so it's easy to assume or imagine the conclusion is that because it was a more accurate and precise injection, that ultimately it led to greater clinical improvement for our patients, which is really what it's all about. So before we jump in and bring in our guest speaker, just to see, we have people from all over the world joining in this webinar and from different walks of practice to see, where do you experience or have you heard of risks and limitations to blind or landmark or anatomical injections for doing pain management or other MSK procedures that you might be due? Have you experienced inaccurate injections, meaning you're missing the target, imprecise injections, so you can't always get it in exactly the same place? Have your patients experienced it as a painful procedure? And maybe you as a clinician secondarily experienced it as a painful procedure too. Have you had to repeat procedures because it's missing or it's inaccurate or imprecise? Or have you heard, done, or seen around a complication where a vessel or nerve or even a pleura was hit during an injection? We'll give this one more second here. Great. And we're going to go ahead and end the pull out. And as you can see, it's really across the board, but especially inaccurate and imprecise injections, a challenge that everyone has been facing and all of us do with blind and landmark injections. And so to really kind of get us past that hump and into how to become better practitioners for our patients, we can't think of a better guest speaker than Dr. Alan Hirahara. Dr. Hirahara is an orthopedic surgeon specializing in arthroscopic shoulder surgery and sports medicine. He runs a busy private practice in Sacramento, California, and Dr. Hirahara speaks and teaches nationally and internationally with published research on arthroscopic shoulder and knee surgery, orthobiologics, and the use of ultrasound. Dr. Hirahara is board certified in both orthopedic and orthopedic sports medicine in the US and in Canada. He was recently appointed to the NCAA Committee on Competitive Safeguards and Medical Aspects of Sports and is currently involved with the Health and Safety Committee for the Big Sky Conferences. He's the medical director and team physician for California State University, Sacramento Athletics, and the head team physician for the Sacramento Rivercats, which is a AAA affiliate of the San Francisco Giants. Dr. Hirahara, we're so happy to have you with us, and I'm going to hand it over to you.
Thanks very much, Oren. Appreciate to be here. So just to kind of get started, we're going to be talking today about visualizing your needle. So why ultrasound will make your injections painless and accurate. These are my disclosures. So one of the biggest fictions I hear is that other physicians always say, I don't miss. Other people may miss, but I don't. And you know, this is a real big falsehood, and that's something that Oren really brought out really well, that anatomic and landmark-based injections just pretty much don't hit their intended target as often as we like it to. We know, and Oren showed this very nicely, that society and agencies all across the world have slowly been coming around and making their recommendations that ultrasound guidance is the gold standard for placement of any kind of thing, like central lines. Also, that's become the standard of care in anesthesia. We know this because that's what all the nerve blocks, epidurals, vascular access, and line placements have been using now is ultrasound. So it's not just MSK, it's all over the place. With central venous catheterization, there's been a significant reduction in iatrogenic pneumothorax and reduced pneumo and hemothorax rates pretty much down to 0. So it's pretty much seen all over that it can really help us do a better job. And we've seen even recently in the news how there have been problems and complications from blind injections, which could have been avoided had they used ultrasound. The accuracy of knee injections, for example, varies, of course, in terms of miss rate from 20 to 40%. And we can see, obviously, that if you have a very large effusion, as we see on this ultrasound, it might not be that hard to hit. It's true. But once you start having minimal to no effusion, you're going to have a tough time getting in there. And that knee joint is something that we've been taught always to come from the front. And this is one of our standard arthroscopic portals. We just simply come in the front. It's a straight shot into the knee. And that's true. But the problem is the anatomy. It's not as obvious as we might think. Here's, for example, a standard MRI in that exact spot. And actually the yellow arrow is indicating where you'd have to get to be in the joint. So that's kind of a long way away. It's not so quick and easy and not so quite under the skin as we might think it is. Even when you have an effusion, it's still quite a distance away. And if you actually measure it, that's actually 4 centimeters in this person's knee away from the skin. So we all use typically a 1.5-inch needle. Well, guess what? That won't make it. It's not going to get there. It means that you've almost guaranteed you're not going to hit your spot like you think you will. So if you give an injection using that technique, you're going to be injecting into something that's not the knee joint, and that's why it's going to hurt. And if you think about it, the whole knee has all these nerve innervations, right? There's all these places where if you inject into, it should hurt. So why should a knee injection, which is a joint space, which is an open area, which has no nerves, hurt? Well, the answer is obvious. It shouldn't. There should be no pain on these injections if you're in the right spot. So what could you hit? Well, getting there, we know that you could hit skin or subcutaneous fat. We know that you can hit Hoffa's fat pad. And of course, if you miss, you could hit the cruciates if you're in the middle, or if you're on the side, you could hit the condyles or cartilage or the meniscus. So there's an awful lot there you could hit if you're not paying attention and you can't see where you're going. So my suggestion is don't try to hit this spot. Don't try to go in this method because you have a perfectly good spot right up here. That suprapatellar pouch, lateral approach, in plane. And it's accessible even when there's no effusion. And it's still going to be easy to hit. It just takes visualization. So you just need to be able to see where you're going. And just like you're not going to try to repair a rotator cuff without the use of arthroscopy, you're not going to be doing an injection without the use of ultrasound. So my
like the way we were taught was to go blind and to, grind the bone and then just redirect, and it was part of the procedure.
Well, yeah, but as you know, if you grind the bone, you're not grinding the bone, you're grinding the cartilage. And
Yeah.
that's the problem, is that you're doing then harm, which will then create damage to that cartilage, which is going to create an arthritic condition as it continues to wear away. So you've done significant harm to that patient, not minor harm. So that's exactly the point. You have to think about what you're doing and why. Our goal here is to do a better job for our patients and treat them well. Well, if you're doing harm, you're not treating them well. So at this point, doing a knee joint suprapatellar injection is actually pretty basic. We kind of start them off with the knee flexed at 30 degrees. And then you simply put that transducer or probe or ultrasound machine just above the patella. And if you do that, this is kind of the image you're going to see. And what's really nice about this is that you can see everything you need to see. Here you see the quad tendon, the joint space, which has an effusion. You can see the fat pad just above that trochlear bone and cartilage layer. But what's also important is that you can see how deep it is. You can see exactly at what level it is. So we know that the entire image is showing us about 3.3 centimeters, and that if we were to come down about 2 centimeters from where our edge of our transducer is and come in flat, you're going to hit that space perfectly. So we can pre-plan our route of where we have to go and what we have to do, so there's no guessing involved. You don't have to just stick a needle in and go, oh gosh, am I in the spot? I don't know, let's look. But you can see. So you can actually see my needle come straight into that joint, you see it flowing into the joint, and you're done. It's just that simple, and you've guaranteed, and it's actually very efficient and very quick. Here's an example of something without an infusion at all. So coming in now, I'm able to see, I'm going to come under that quad tendon, and I'm come above the cartilage, and you can see the flow occurring. That's lateral. That's actually more medial in this picture, so to the left. You can see the flow, so I was in the right spot. So I made sure I got into the proper area, I was in the joint, I saw the flow, so I know I'm in the right spot. Another fiction I hear a lot is that ultrasound is going to take too long. I don't have time in my office. But the reality is that actual proper incorporation in office injections actually doesn't just add negligible time, but it actually makes you more efficient. And that's a fact for me, because my secretary will set up the ultrasound ahead of time, get in the person's data. I just simply walk in and use it. And an example of that is here I'm actually doing this. So I've got the ultrasound on. I'm going to clean up the area using Sterile Technique, because I don't need a large area. I just need the area where I'm going to put my needle in. And then once I've sterilized it, well, just don't go back and touch it again. And this is something that I do all the time when surgeries. I'm very careful about, Sterile Technique. Of course, take your pictures, make sure you document, and then pretty much you can see the needle go in, and you can see the needle on the image enter into that effusion. I gave my shot, and I'm done. I'm out. It's that quick. This makes it much more efficient because there's no guessing games. There's no guessing where I'm going to go in, what level I'm going to go in, at what point I'm going to go in. My shot is already set because I've pre-planned it. So here's an example of doing a intra-articular knee injection for using hyaluronic acid for DJD. And you can see it's pretty easy to set up. And you can see on the screen, I'm ultrasounding. And one of the key points is to try to make sure you really set it up nicely and you can see well. So you can adjust your hand position. You can see I'm kind of adjusting my hand forward and back, tilting either direction, finding the optimal image and the optimal angle to go in. And this is important because that way then you can optimize your image. You can optimize the bone. You can make that bone really pop. You can make the tissues pop so that when you see it, you can really come in nicely and know exactly where you are. At this point, same type of procedure. Once I've determined where I'm going to go in, it just needs to be cleaned up, standard sterile. Here I'm using iodine, then alcohol swab afterwards. We'll use Hibiclens or whatever you want to use is fine. But here I'm using ethyl chloride to numb the area up so the patient doesn't even feel the needle going in. And then at that point, just simply replace, get my image back, and then pre-plan where I'm going to go. Then you can just enter with the needle. You'll see it come into view, and if you're not quite come into view. You can sometimes just adjust your image a little bit, but you can see it quite nicely right there, and I'm clearly in the joint. And as you inject, it's done. And it's just that easy to do. And it's reproducible, and you can guarantee and these patients are going to have no pain. And that's kind of a key point, is that when I first started doing this, I actually thought I was super good at injections, but then once I started having these patients come in, once I started having this ultrasound on my hands, all of a sudden, no one had pain. And I started realizing, oh my gosh, those people that had pain, it's because guess what? I was missing. That was my fault. So the accuracy is not just for knees though, it's for everywhere in the body. So the accuracy of shoulder injections likewise. 30% of injections to the subacromial bursa, even done by fellowship trained shoulder surgeons, miss. And that there have been numerous studies, as Oren said very well, that unfortunately definitely are better, and you get better outcomes using ultrasound guidance. So here, just to give you an idea, that the subacromial space, for the most part, unless you have bursitis, is a potential space. So it doesn't actually have a large volume to it. So you need to hit an exact spot. It's less than a millimeter. And that area is sometimes missed on some people using ultrasound even. The problem is that some people think if you just come in and ride under the bone, you're going to hit it. Well, that's not always true, because it turns out that muscle can actually ride up against the acromion. And even when you come in an arthroscopy, you can't always create that space well. So it's a misthought to think that you can just come in under the bone and you're going to hit the subacromial space. It's actually easier to visualize it and then hit it using ultrasound. And on ultrasound, what you're looking for is, a lot of people will think that double hyperechoic line right there is actually above that spot is going to be the bursal space, or that is the bursal space. That's not true. That's actually a fat layer. That's a subdeltoid fat layer. And your subacromial space is below that. And so that hypoechoic black line below that hyperechoic white line is actually your subacromial space, and that's where you want to be. And that's just above the supraspinatus tendon. So doing the subacromial injection, we want to bring that humeral head away from the acromion so we can be able to see it better. And so by doing that, you take that ipsilateral hand, place it on the ipsilateral hip, and duck that elbow back. What that does is it's going to actually bring that humeral head away from the acromion, expose the tuberosity so you can actually see better. However, now you're actually not completely in line with your acromion as you might think you are. So you're in the plane using the contralateral shoulder to ipsilateral hip to place your probe onto, to be able to get the proper plane to see the actual images and the fibers. And here you go. So now we have a very nice image showing you that. And here you can see the subcutaneous fat. You can see the deltoid muscle. You can actually see the subdeltoid fat, as I said, that hyperechoic line. Then the subacromial space, that hypoechoic line just below that. And then below that is going to be the supraspinatus tendon. And then, of course, down to the bone, the tuberosity, and to the left you can see the bit of the humeral head. So in doing this, we want to optimize our image. So this is an example of how to optimize the image. When I put my probe on, you saw it be very kind of indistinct tissue. But then as I moved my hand, that bone of the humerus, that subdeltoid fat, became much brighter. And that's what you want to look for. And the best way to do this is to optimize your bone. If you can get that bone to look really nice, really white, that cortical edge really white, that's a good spot, because you want to be perpendicular. You want to be perpendicular to your tissues, and if you're in that proper plane, you're going to get a much better image. You're going to see better. Do not accept a poor image. Really work on your placement of your hand to tilt, just subtle movements up and back, and be able to optimize that image. Once you do that, you're going to have a much easier job giving these shots. So here's your subacromial injection. So as you can see, we've got that subacromial space coming in with my needle. I'm able to fill it up nicely, and you'll see it going all the way medial. If it just fills that one small area, you might be actually in the fat, or in the deltoid, or in the tendon. So you really want to be able to see it go all the way across and fill, because you don't want to create a bubble. That's the way to tell if you're in the space. Now, ultrasound improves reimbursement. Big fiction is that people say, oh, it just costs too much. Well, that's not really true. Before it used to be, but no longer. And also, billing can be done in a very effective manner, and implementation actually will improve your reimbursement. You'll actually get paid more money by doing it this way. So this is actually something that can be a money maker for you, and honestly will actually just be able to reimburse anything you paid for that ultrasound pretty quickly. What we did do is that I did publish a paper back in 2016 on a coding and reimbursement guide in the American Journal of Orthopaedics. And this goes through shoulder reimbursement, and it's pretty comprehensive, and a lot of it still applies today. Not a lot has changed since that time. So I recommend you kind of go and take a look at that. Now the Clarisus L15, this new HD, has really become really an amazing little unit, and I really like this because it's handheld, it's wireless, and we'll talk more about how I use it wirelessly, not just in my clinic but also in surgery and on the field, because it's just such an easy, efficient, quick little device to use. It works with the iPad, iPhone, and so for me this is a huge game changer, not having to carry around a big unit. It's inexpensive, it's lightweight. There are less expensive ones, but I'll tell you the difference in the quality of the image is huge. So I really recommend before you buy anything, go try them all out. Decide what you like, but really this is a great way to start off because it's so inexpensive. It can get you started with a good unit that works well. And so that's kind of why this is a big part of my use. Having it being able to be used with my iPad, my iPhone is just great. So I don't have to carry lots of equipment, and I can quickly just pull something out and take a look at something. It's very nice. It also has needle enhancement, and I really liked their needle enhancement a lot. And the reason why I do is it always kind of made me think of a similar lightsaber that I always thought was kind of cool. But honestly, I actually don't use needle enhancement too much, because if you really stick to, the technique of being perpendicular, keeping that needle in plane, you're going to see it really well. So here you have another video of me doing a subacromial injection, and as you can see, this is going to be for tendinopathy. He has a lot of swollen supraspinatus tendon, and so we're going to be doing a subacromial cortisone injection. And you'll see his hand was right on his hip, got that elbow tucked in nicely. You can see that my plane is the top part going from contralateral shoulder to ipsilateral hip. So my probe placement on his shoulder is in that plane. And as you can see, I'm kind of tilting back and forth to optimize my image and getting that bone to really pop white, to get a really hyper-echoic signal. And that's going to give you a better image. Now this gentleman previously had surgery, and so his subacromial space is not easily visualized because that normal fat layer is not going to be visualized well on him. And also when we give the injection, it's not going to create that nice beautiful plane you see when you're injecting a non-post-surgical shoulder. So with this gentleman, unfortunately, it is a little bit harder to get in, harder to see, but you can tell, and you want to just ride, and you can see the line that's just riding above that supraspinatus tendon, but you're not seeing the hyper-echoic line you normally would in the perfect anatomy of a patient that hasn't had surgery. So, but you can do it, and that's another reason why it's important to use ultrasound, so I have the best chance to give a better outcome for him. So I'm able to come in, get to the exact spot I want to be in, and advance along the plane that I know it should be at, being able to visualize where I want to be and where I want to inject. So for someone like him... Is that just a
small 25 gauge? Is that like a regular 25 gauge needle you're using there?
Yeah, the needle is not a special needle. It's not a special, like I say, they make special, hyperechoic needles that are visualized easier on ultrasound. This is not one of those. It's just a very basic, normal needle, and you're seeing that it's very easy to see. It's not that hard, and honestly, it's because I'm adhering to standard, technique. I'm trying to stay as parallel as I can be to my machine, and that way, then it's going to give you the biggest pop for your money with that hyperechoic signal, and that's it. And honestly, I would never want to do that without that machine because I could not guarantee I'm in the right spot. It'd be hard to tell. So another fiction that I hear is, what I do works, and I just don't need it. It's not necessary. I do a great job. And that's might have been good in the past, but in today's world with technology and with the changing paradigms that we have with orthobiologics and the ability to do different things in the clinic, that just doesn't work anymore. It's time to grow up and get to the next generation. This is something that I think is really critical. Corticosteroids, for example, which used to be the only injection that was ever given practically, it's just no longer for me in my paradigm much. I use it so little. It softens, damages cartilage, weakens and ruptures tendons, has potential to give you AVN or thinning of the bone, increased risk of infection, and then of course many more. Diminishes activity of your immune system, temporarily increases your blood sugar, so if you have a diabetic you better be careful. Can give you soft tissue atrophy, crystal deposition, steroid flare, hypopigmentation, thinning the skin. The list goes on. The problem is that cortisone has really got a lot of issues and you have to be careful with it. And I still hear so many patients tell me that they didn't know, that the doctors never tell them these risks. And that's not okay. With today's informed consent, you have to tell people the reality and the risks that they're undergoing, even with just simple cortisone. We think nothing of it, but that's not okay anymore. I mean, especially in my world, doing surgery, one of the biggest things that I have to deal with is that these patients will come in having had a primary care do cortisone for them, but they didn't realize that there's a lot of negative effects. So for example, there's now significant studies that show that cortisone injections prior to surgery for rotator cuff repair significantly increases the risk of revision. And this isn't just with, multiple shots. Even just one shot can also give us problems.
I think it also speaks to, the literature and the review. There used to be all these papers that suggested, well, it was close enough. Our injections were close enough to get reasonable clinical outcomes. And I think that's really from the steroid paradigm. Like you drop the steroids like a nuclear bomb, close enough. But now as you really have to kind of get in there using some of the adjuncts, and close enough isn't going to cut it, I don't think, right?
Yeah, no, you're absolutely right, Oren. I totally agree. And that's dead correct, is that, cortisone doesn't work as locally as we think it does. It really is a systemic drug, and that's how you have to consider it. And so realistically, doing these shots, you're affecting the whole body, the whole system. And so that's why I'm really careful with these shots. And as you can see here from this research, just doing 2 or more injections is going to significantly increase the risk of revision, and the closer the time index from doing those injections to the surgery also increases your risk. So these are not benign. You have to understand that. And as a shoulder surgeon doing a ton of cuff repairs, I cannot have my increase of revision, increase just because of a shot. So this is just not okay with me. So that's why PRP for me is a big deal. And that's why orthobiologics is a big deal. It was first reported in 1969, the first report of PRP. This is not a new thing. It is used extensively in the 80s by a lot of different surgeons in different areas, in open heart, in meniscus, in ophthalmology, in the dental community in the 90s. And frankly, the FDA approved PRP use in 1999. And here we are in 2021, and people still think it's experimental. And that's just ridiculous in my book. We know at this point that PRP can augment proliferation of tenocytes, osteoblasts, myocytes, diminish inflammation, diminish pain, augment HA, and augment stem cell migration and proliferation, because this is basic science. That's how our body heals. And so all we're doing is taking what we know the body can do and applying it where we want it. Now, is this going to, grow us a new limb? Is it going to regrow our cartilage from nothing, from injection? No, it's not. And so we have to be realistic about what it can do. But we have level 1 evidence. We know that PRP is superior to HA or placebo. We know that PRP is beneficial in tendinopathy and partial tears. And it can be beneficial to the point where you can actually cure someone and avoid potential surgery. And so we have to understand these things and how to use them. And our patients are going to come and ask for these things. And now that they have to pay for them because it's going to be a cash pay situation, to me, it's reprehensible that you're not going to use ultrasound to get the best possible outcome for these patients, and that you're just going to guess. I think that's not okay. You have to do a better job for your patients. So here's an example of a patient that had an Achilles tendinopathy, and this is me. This is my Achilles back in 2018, and as you can see, my tendon was 6 millimeters wide. It was not small, and normal is 3. Now, we always think bigger is better. No. This one hurt a lot. And I let one of my ex-fellows put PRP into my Achilles tendon, and it hurt. So let's be clear. If you put an injection into a joint, if you put injection into a subacromial space, it shouldn't hurt. But if you put it into a tendon, like here, like we did intentionally, it hurts. It doesn't feel good. So think about that. If you have a patient that you've been doing injections on and they are having pain, where you shouldn't be having pain, you missed. Please accept it, please realize it, and please get better, because I had to, because I was definitely missing. There's no question I was. But when you put it in a spot that you have to, it can actually do some really good work. So here it was again in July, and actually just 6 weeks later in September, this is what my Achilles looked like.
I think it's worth keeping that screen on, you know, because look, like the size of where you want to drop that PRP, right? That's like a couple millimeters by a couple millimeters. There is no chance you would hit that spot blind, right? And get it exactly where you wanted. And especially, you know, I know people inject steroids around tendons and things for inflammation and chronic tendinopathy. I mean, I'm sure you see it on the other end. And, you know, it just seemed like, oh, wow, what are we doing?
Yeah. And you know, Oren, you're absolutely right. You know, the biggest things I see also is they say, oh, yeah, well, I'm not in the tendon. How do you know? How do you know you weren't in the tendon? Because if you were, cortisone is detrimental and increases risk of rupture. So that is not okay. So to me, even more so, if you're going to be peritendon, you need to use ultrasound to make sure you're not in the tendon where you might be. So we also know that stem cells are really the thing that do the work in our body. That's what does the work of healing. We know that PRP only has stem cells migrate and proliferate, but the PRP doesn't actually do the healing work itself. And so the thing that I got started in then a couple years ago was doing a lot more stem cell injections. But what I realized is there was actually no research on how to ideally take stem cells and what was the best ideal method. And so the thing that I started looking at was we did this MRI analysis of the pelvis, and we published this back in 2018, showing that actually if you take a look at the pelvis anatomy, the PSIS is actually a table, not a point, and it's about 1 centimeter wide. It's not perfect, but it's 1 centimeter wide. And it turns out if you enter at the medial aspect of the PSIS and go a specific 24 degrees lateral, you actually have 6 to 7 centimeters distance, unlike your standard 3 centimeter distance if you come in perpendicular until you hit the far wall. So if you come in perpendicular, you have a chance to enter into the SI joint. Whereas if you come in at the specific spot I'm saying and the proper angle, you're going to have 6 to 7 centimeters on average until you hit the opposite wall. That's a lot of space. And so it's going to be so much safer to get in. And so what we realized was the ideal situation was to use ultrasound, find the medial aspect of the PSIS point, enter at that spot, angle appropriately 24 degrees lateral, and then you're going to have a good amount of distance to safely take your actual bone marrow aspiration. And so we realized that this could not be done without ultrasound because you had to be point specific. And if you were too far medial, too far lateral, too far north, too far south, you're going to hit a neurovascular structure. And so we had to make this as safe as possible. But in this region, it's totally safe. There's nothing you're going to hit if you can do this appropriately, but you have to visualize it and see it. Again, ultrasound being absolutely critical to this. So here's another video on using PRP and using ultrasound. So this gentleman actually had bad lateral epicondylitis, very painful, had done just about everything else short of a cortisone, knew not to do a cortisone, came to me for us to do a PRP injection. And yes, I'm the leukocyte poor end. I don't do leukocyte rich. I'm not on that bandwagon. I think leukocyte poor is definitely better. I've done both on my patients, and I found the poor works more effectively in my hands for my patients. Being able to then visualize where I want to go is critical. So what I do is I visualize where I'm going. I cheat. I move my probe over to be able to give myself plenty of room to come in. I do an in-plane injection. I get down, become parallel, so I can see my visualization of my needle well. I can see it coming down to that bony attachment, and I can then pepper the entire region with my PRP. And I tell my patients flat out up front, I'm going into a tendon, it's going to hurt. It's not going to feel good. And so I give them up front some medication to take ahead of time, because with PRP we cannot use lidocaine. You can't numb up, unfortunately, inside, because if you do, unfortunately, it's going to inactivate the PRP. We know that from our basic science study. So at this point, this is the best way to do it. I tell the patients it's going to be about 5 to 10 seconds of pain. You can get through it and we'll get done. And so that's kind of how we do them from now. because we put in about, on average, 3 to 4 cc's of PRP to the region. So, tips and tricks. For me, optimizing your image is the key. So you have to really be able to scan well. And so scanning well and optimize that image to be able to see your anatomy well in terms of getting the bone to pop, your ligaments, your tendons, your fibers even of some of the structures to pop is important. Because if you do that, not only will you see better, you'll be able to go and get your anatomy better, but also it'll improve your imaging of your needle. And as you saw, my needle was very hyperechoic, but you have to stay perpendicular as possible to your tissue, stay perpendicular with your needle. If you're going to come in at a high acuity with your needle, as you sometimes have to do with hips or some certain structures, well then definitely use the enhancement of the needle. That's where your hardware will help a lot. But look at that bone. Use the bone as your reference, because the bone will give you the key to how good your image is. And then of course, pre-plan your approach. Use Doppler, look for vessels, use your depth measuring, check your needle length, pre-plan ahead of time about where you want to come in the skin, how you're going to come in flat or acute, and how you're going to get there. Sometimes you have to come in a bit high, go over structure, and dip back down, as you saw me do in the knee sometimes. And then obviously go to a course, do a site visit. There's lots of places now you can go learn, and we've done tons of courses in the past. It's something that's easy accessible. But ultrasound will really help you take this up a notch. It'll improve your accuracy, it'll improve your patient satisfaction, improve your workflow, improve your reimbursement. And at this point, adding orthobiologics, I think your paradigm will diminish your cortisone use, give you a better chance to have a better outcome for your patients. So how can you get this info? I do have a website. You can take a look at it, hiraharamd.com. I have lots of references. I've got lots of publications on ultrasound and biologics and surgical use, also in surgery, because I use ultrasound in surgery quite a bit. I've created a lot of techniques for surgical use, and I really think that this is something that is the future. We are there. We have the technology. In my opinion, we just have to use it. Thank you very much.
Great. Thanks so much, Dr. Hirahara. And I encourage all of our participants here in the webinar to definitely use the Q&A. I see there's a lot of questions here, and we'll have plenty of time at the end. We want to wrap up just with a couple things. First, a summary of ways I think Dr. Hirahara really brought that point-of-care ultrasound can help your practice with MSK is that it optimizes injection accuracy for improved patient safety. So how kind of quick and easy it can be, and really kind of pushing towards the standard of care to use ultrasound to guide any needle in the body at this point. And it helps also increase precision. So you get consistent relief where you're expecting it, and you expect to put the medicine where it belongs. And that also allows a reduced risk and costs. You use lower volumes, you get a more targeted application of medication, whatever you're using or placing into patients depending on the procedure that you're working on. And I don't know if you noticed, but none of Dr. Hirahara's patients flinched in any of those videos, really suggesting that the procedures were way less painful and almost painless, I think, most of the time. And I think you could probably speak to them and hear that it really leads to improved patient satisfaction, and word gets around. I'm sure you've kind of experienced that. You're like, oh, those other doctors, why didn't they use the ultrasound? Or it was so painful when I got the injections somewhere else. And when someone shows up, we like kind of take pictures of people texting while they're getting their injections and things, and they don't even notice. They're surprised you're done sometimes. So it's word definitely gets around in the outpatient practice, and it can really help out your practice. So I think before we hand it to Janez to take it home, we just kind of wanted to emphasize how this is a really great way to get into the MSK world and into procedural application is with a small handheld. It really brings pretty high performance imaging into your practice and enables kind of a step into the game. And there's a lot of other tools that can be brought in with using handheld ultrasound in MSK practice. And it's really open. I know we have participants from across the spectrum of practice, not just orthopedic surgeons here, but people in primary care, physiotherapists who are doing interventional procedures and different rules and regulations across the world. But anyone who's doing interventional care really could benefit from doing image guidance on their procedures. So I think before we close it out, Janez was going to show us a brief demo and then take us home. And then please use Q&A. There's a lot of questions. We'll do our best to get to as many as we can.
Thanks, Dr. Frankel, and thank you, Dr. Hirahara. I'm excited for the live Q&A. having had the opportunity to chat with some of your patients when we did the filming on site. It was absolutely phenomenal, night and day experience in being able to work with you to manage their pain. I'd now like to take a minute to share a video we captured with Dr. Frankel to give you a look at our latest Claris Needle Enhance 8.0. It's particularly useful for more novice ultrasound users. Needle Enhance is an upgrade option available with Claris scanners that delivers artificial intelligence to light up your needle during ultrasound-guided procedures. Let's start the demo.
When doing nerve blocks or musculoskeletal procedures, Needle Enhance can help my needle light up all along the shaft and identify the bevel in the screen. With Needle Enhance, I can watch my needle come in and light up even when it's not an echogenic needle and see it really approaching my target just prior to injection. It's important that the needle icon on the screen matches the direction that the needle is coming in from. If I was coming in from the other side, I would flip the icon to the other side, and you can see it loses Needle Enhance coming in from the opposite side. Using Needle Enhance helps improve patient safety and accuracy by identifying adjacent structures and ensuring my needle was in the appropriate location during the procedure.
So as you just saw, Claris Needle Enhance improves visualization, lighting up your needle for easy identification, while Claris HD scanners deliver high definition imaging of the surrounding structures for clear visualization of your injection target. With frame rates up to 30 frames per second, we see higher angle sensitivity and crisper needle imaging. Our software uses AI and a multi-angle approach, automatically optimizing the image in real time for your acquisition angle. So there's no need to set or manually adjust the angle. All that to support faster visualization during your busy procedures. Now, just before we open up the floor to questions with Dr. Frankel and Dr. Hirahara, here's a quick poll for you. We'd love to help everyone continue their journey in bringing handheld ultrasound to their practice. If you're curious about putting blind injections behind you, please do complete this poll to get additional information. Claris is available in over 90 countries. If you'd like to get a quote and get pricing and availability in your region, please select that first option. If you'd like to speak to an expert, we'd be happy to set up a call with our experts so that you can chat about point of care ultrasound for your practice. You can book a Claris demo. As you saw today, Zoom is a little laggy when we've got thousands registered for a webinar, but we'd be happy to do a one-on-one demo with one of our Claris clinicians so that you can see it in action. If you'd like to discuss features and compare features across different systems, we'd be happy to set up a call again with our experts. And you are invited also to watch more video tutorials from our Claris classroom. If you click that option, we'll be sure to send you some tutorials. So now, as you take your time with that poll, I'll just give you a little bit more information about Claris. Claris linear scanners are designed to deliver several advantages. Claris is unrivaled for near field and high resolution MSK imaging in a wireless device. This best-in-class imaging is what you need for clear MSK visualization. As you saw today, you get a clear view of tiny nerves, vascular structures, tendons, and so on for safe ultrasound-guided injections. And the secret lies in each scanner containing 8 beamformers and 192 elements that deliver the performance and image quality only found in traditional systems, but at a fraction of the cost. And with artificial intelligence to replace complex knobs and buttons, it's as easy to use as your smartphone. Claris is also wireless, freeing up space with zero footprint for high portability in a variety of settings, from the clinic to the sports field. You get free movement with no wires getting in the way or touching your sterile prep areas. And with no wires, Claris is also so much faster to clean, disinfect, or fully encase in a sterile bag. Only Claris delivers high-performance linear wireless scanners with a free ecosystem that includes free apps for your iOS and Android devices with free updates, unlimited cloud storage to capture and manage your patient exams, and for unlimited users at no additional cost. Claris is so affordable with no subscription fees. And you can use a single device to share among physicians in your practice. I'll give you 3 more seconds to complete the poll. 2, 1. Thank you. We'll get back to you in the coming week. I'd now like to welcome back Dr. Hirahara and Dr. Frankel to answer your questions. Please use the questions icon in the menu bar to ask your questions of our great doctors. Dr. Frankel, if I can invite you to moderate, please.
Yeah, happy to. There's a lot of questions. We're going to do our best to get through all of them, and I might group some together to make it more efficient. So let's see. First question people want to know, Dr. Hirahara, is calcific tendonitis. Do you treat it? PRP? Steroids?
So that's a yes no answer. So it's one of those things where calcific tendonitis, it depends on, number one, if it's even symptomatic. So sometimes calcific tendonitis doesn't even need to have any treatment at all, and actually over time it can go away by itself. So it can be a self-limited disease. So sometimes physical therapy alone is adequate. Second, if the problem is inflammatory and not the calcium, then even though I don't like cortisone, cortisone is acceptable, but realize it won't get rid of the calcium, and you can't go into the calcium at all. So it's just simply a symptomatic inflammatory relief. I almost never use that at all myself, but I'm not saying you can't. If it's a small lesion, PRP injection into the calcium under ultrasound guidance is appropriate. That actually works really well. But again, it's size dependent if it's a relatively small piece. If it's a larger piece, then it depends on, for the most part, what phase is it in? If it's in that kind of gel phase, it's going to, puncturing, it's going to help get rid of it. If it's kind of that in between, starting to get chalky phase, sometimes the lavage will work with saline, and that's necessary to do, again, under ultrasound guidance we can do in the clinic. And if it's really, really thick, tough, just solid, then it needs surgery, and you got to go in and scoop it out. And so the answer is, it depends. That's the problem, is that yes, a lot of things can work, and as you do more of these and you get a little more experience, you'll understand that size differential, because it's all about the size, it's about the phase it's in, what you think is wrong with the patient, and then what they need. So sometimes I'll do therapy, sometimes I'll do PRP, sometimes I'll do a lavage, sometimes I'll take them straight to surgery. So it all depends on where they're at and what I think is going to be most effective for them. So unfortunately, it's not just one thing.
Got it. Is another word for the lavage, is it the barbotage?
So right, so lavage is obviously it's where you're going to take a 16 or an 18 gauge needle, and under ultrasound guidance it's going to be attached like a 50 cc syringe of saline, and you're going to go in sterilely and pepper it. And what you'll do is, the whole goal is that you're irrigating. And I've actually got some video of this, watching me do this under arthroscopy. So actually under arthroscopy, I actually was able to put a needle in and irrigate it out, and because I wanted to see how it works. I was doing surgery for this person. I wanted to see how effective it was. And I opened it up to see how much more I had to scoop out, and actually did a pretty good job on this patient, where it started making me think, okay, did I not have to take him to surgery? Could I have done this in the clinic ahead of time? This is something I did many, many years ago to kind of teach myself about different options I can have.
How often are you visualizing vessels or putting on Doppler when you're doing scans, and how does that inform your practice?
Yeah, great question. That's something that if I'm doing a hip, which I don't do much of, I do it every time. If I'm doing an area that I know has vascularity, I'm absolutely doing it every single time, checking the area, checking my approach, checking the whole area that I'm going to be coming in with my needle, so I can plan my approach and I'm not going to hit something. For shoulders and for knees, there's no vessel. I mean, for the most part of where I'm going, so I'm pretty much never doing that. However, if I'm doing it like to check up on a rotator cuff repair, an SCR that I've done post-surgical, then I am using Doppler to check on the vascularity of the tissue, vascularity of the implanted dermal allograft. In fact, we did a study on that. And we actually showed that revascularization was apparent on that graft implantation in shoulder surgery.
This question, I feel like it's at every webinar, and it's no surprise. How do our participants learn more about how to do this and really bring it into their practice?
Yeah, so that's what I was saying earlier, is that there's courses everywhere. I mean, they're being taught now all the time. I mean, I think I was a course director for my very first course back in 2010. And, I've been teaching courses for 11 years now on ultrasound. And also I have people that will call me up and they'll come visit, they'll do site visits and come watch for a day and come learn and come visit. We'll go have dinner and hang out and talk. I have people in all the time. So, that's really, you have to do what, you're comfortable doing and what the best way for you is. There's now webinars like this to learn from and check stuff out. But to be perfectly blunt, how I learned and the most effective way was I simply had a machine. I got a machine. I then pretty much got a CD-ROM of an MRI, a DVD, you know, and
You're
then
dating yourself.
I am dating myself, right? But I would scan through and you have my books open and I'd just be scanning and reproducing these images I had in MRI, and so that I could learn how to make those images. So I could reproduce that MRI with an ultrasound machine. And that's how I did it. And then one night I kind of came home and I said, hun, my wife, I'm like, I've got a bottle of wine, a video. Take your clothes off. It's gonna be a little cold. Sorry.
Some gel.
And I just had some gel, and just like, you know, it just had to practice. You know, you just gotta practice. And the other thing I did, honestly, is that every MRI I got on my patients, then if I had like a positive finding, like a cuff tear or some tear, I would just say, excuse me, I'm not charging you. There's no money here. Can I please scan you so I can learn? And I would then just scan and find that pathology so that I could learn what was real, what was normal, what was pathologic, and I taught myself.
Yeah, I can't emphasize that enough, of just really scanning and, you know, comparing to whatever gold standard you have available, what other imaging is around, well, until you learn and you kind of check your work against whatever your normal standard of care is. And it kind of also, you know, what you were mentioning, scanning your patients, I just wanted to emphasize, like, patients love it. They love to see their pathology. They love to know what's wrong. You can flip the screen, show them, you know, here's your tear, here's your whatever effusion. I'm like, oh my God, there it is. And it's not, it builds confidence, and there's not a guessing game, and it really helps on all ends on that one.
Yeah, in fact, you know, we were talking earlier about, you know, patient satisfaction and patient, you know, your credibility. Well, when the patient comes in and I'm scanning them, they're like, well, what are you looking at? So I tell them, and I said, so what you're going to see is you're going to see the needle come in here. It's going to hit this spot right there. It's going to go right there. And that's where I'm going to put the shot. And so when they see the needle come in, they see the needle and it hits the spot I told them it was going to hit, and I do it, and they're like, yeah, that's great. You did it. That's amazing. You know, so they know what they had done was right, because they saw it. They saw it.
Do you, a couple questions around your workflow. Do you archive images and record?
Well, you know, I'm gonna date myself some more. We actually don't have EMR in my clinic, and so we still have paper charts, and so we still print out every one of the pictures to put in the charts. And eventually, when we do transition to EMR, you know, that DICOM ability and be able to save it and put it directly into their chart. Now you need to do that. That's a requirement, because like when you bill for this, one of the requirements is that you document not just what you did, but you have to have the images. You've got to store the images and everything. So if you do, like, you know, and you bill for a complete shoulder exam under ultrasound, you've got to document every single picture, every angle, short axis, long axis, supraspinatus, infraspinatus, subscap. You know, you've got to document all that. You know, so that's why I'll admit I almost never bill for a complete exam, because I'm not doing complete exams. You know, so I'm only billing for limited exams, like almost every time, because I don't have the time. I'm not a radiologist. That's not my goal. I'm only gonna go evaluate what I need to evaluate.
Yeah, and then what I've heard from most practitioners, I'm in Canada now, but when I was in the States and around everyone, particularly there with the billing, yeah, it was people usually billed limited exams, but the archival was, you know, when I learned it was carts, and archiving with the carts was a real challenge. And now with the cloud-based infrastructure, it's so easy. Like, well, I have the archival right here on the cloud, and you pay, you know, it's built into the system, and it's really quick and it's secure, so makes that part of the requirement really easy.
Yeah, it is true.
Another question, there's a lot of variations on this question, so let me see, how do I capture it all? Sterility. Yep. You showed kind of your approach to, you know, it's people are expecting maybe a different approach sometimes with the ultrasound, which we learned from central lines, where we worry about line infections, which is, you know, full sterile drape, prep, OR style. So I get it, there's two parts to this question maybe. One is, you know, can you speak a little bit to your workflow? Like, have you experienced infection? What do you think the infection risk is with the workflow you showed us? Is there a place for a more sterile workflow? And then maybe that speaks to also, do you ever use these in the OR? If it's different. Yeah,
so these are great questions and absolutely necessary. Now, here's the problem. I'm a surgeon. I've been in practice for over 20 years. And so from my point of view, I know how to work with Sterile Technique. And I know how to sterilize an area, and I know how to never touch the area again, except with whatever I need to stay sterile. So if something's unsterile, it never goes on that area. And so I'm very good at that, and I do that every single day in the OR. And so taking that into my clinic, Because obviously when I first started doing all of this, you know, I was taught by non-surgeons, and they were like, okay, you have to use, you know, this huge prep, this huge sterile drapes, this gown, this mask, the hat, the boots, and I'm like, why? It's a damn shot. Like that's ridiculous. You sterilize the area and then you just never touch it again except with your sterile needle, and you never touch your sterile needle anything but the sterile skin. So, you know, in 20 years, I've never had an infection from a needle. Never. Never. Zero. 100% zero. And so, you know, it's just about technique. And so, yes, if you're unfamiliar with sterile technique, yes, please use a gown, use sterile prep, use sterile gel, use a sterile cover, use sterile mask, you do everything. That's fine. There's nothing wrong with that. But if you're familiar with sterile technique, you know how to do it, you know how to clean it correctly, you know how to make sure that your gel never gets on that area, you know how never to touch it with your probe, you know how to make sure that you just put the needle into the sterile region and never touch anything else, you're fine. You don't need to do the rest, because it's all about sterility. And so that's what it comes down to, is your comfort level with what you're doing.
Do you take the probes into the OR?
All the time. So I have numerous techniques of where I use ultrasound in the OR, and that was the problem, is that when I had to have those wired based systems, literally they're not very long. So I would have to have someone, like I'd have to have a nurse holding the ultrasound next to my sterile field as I have a sterile probe cover over it as I'm trying to do my surgery. I mean, it was horrible. So now we just take this probe and we dump it into a sterile bag and keep it sterile, and I can just use it off field, and I can have the monitor wherever I want. I can use a really big TV screen. It's great. So there's a lot of different options I have to do this. And so, yeah, and I've published several techniques on ultrasound guided surgical applications. And what I don't understand is why surgeons are so afraid to use ultrasound, because we use arthroscopy, we use fluoroscopy, we use all these other, you know, techniques in the OR to help us do a better job. Ultrasound is just another tool that we use to do a better job.
Yeah, what do you think the limitation is there?
Just imagination. I mean, I got to tell you, I mean, the things I've come up with are like doing an ALL reconstruction or an MPFL repair or an MCL internal brace, you know, or all of these different techniques, a biceps tenodesis, using ultrasound to place where my portals will go. So when I enter in with my scope, I'm dead right on the structure. All these techniques are just because I had an open mind to try a different way to do it. I'm not special. It's just I was lucky to have thought up a few things that honestly make my life easier, and I do a better job for the patients.
Great. Last question. So can you speak to the needles you use? Just some people want to know what exactly you were using.
Yeah, so the needles, the short ones are 1.5 standard 22 gauge needles. And then the long ones you saw, like if I use a long one, it's just a standard 22 gauge spinal needle. That's all it is. They're all basic needles. I don't use special needles. I don't need them. I will say that if you're doing a lot of hip injections or with high acuity, you might need some of these special needles, because sometimes it doesn't show up. But then that's where you try the needle enhancement, and sometimes that's more than adequate. But for my own purposes, I try to stay as parallel into my probe, into my plane, and so that my needles really light up. So I don't really need them.
Yeah, and that's also a technique for keeping sterility, is right, not going right at the probe where the gel is, but you can actually go a little bit away and then go parallel and make sure you hit your target.
Yeah, my entry point is usually 1 to 3 centimeters away from my probe on average. And then the key is just you have a really stable base when you hold your probe, so that you're not moving. You just got to have a stable base so that you don't slide by accident.
Okay, well, we're at the top of that hour here. I want to respect everybody's time.
Thank you so much, Dr. Frankel, for moderating our Q&A. And thank you so much, Dr. Hirahara, for all of your tips and tricks and masterfulness in teaching us how to use ultrasound guidance for pain injections. If we didn't get to your question, we will follow up with you by email in the coming week. You'll also receive a copy of the slides and webinar recording as well, so do keep an eye on your inbox. Again, a huge thank you to our doctors for today's session and their dynamic presentations, and a big thank you to all of you for joining us today. We hope you have a wonderful rest of your day and keep scanning. Thank you so much.